All right. Good morning, everybody. Welcome to our weekly medical grand rounds. We are back in Clinical Sciences building. So those of you that are here and want to run down, there's coffee here. You're welcome to join us. We have a few people in the room and we're all safe and masked. So I'd just like to start by respectfully acknowledging that we are located on Treaty 6 territory, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to enrich our vibrant community. I'm absolutely delighted to introduce today's speaker, who is one of our newly minted professors. Dr. Clarence Wong is professor and also division director and section chief of gastroenterology. He is a therapeutic endoscopist focusing on the management of GI cancers. He's currently the medical director of both the SHARP GI Central Triage and endoscopic ablation programs. He helped develop and lead the SCOPE Edmonton Zone Colon Cancer Screening Program and was the provincial medical director of the Alberta Colorectal Cancer Screening Program. Dr. Wong is past president of the Alberta Society of Gastroenterology and was appointed fellow of the Canadian Association of Gastroenterology in 2020. Dr. Wong has received awards for excellence in medical education, including the Certificate of Merit from CAME, the University of Alberta Rutherford Award for Excellence in Undergraduate Teaching, and also been awarded the AMA Long Service Award. And I can personally tell you that he is an outstanding leader and educator because he's done a stand-up job over the past few years, leading the GI division clinically as section chief and now taking over as DD and section chief. So with that, I'm going to hand it over to Clarence.
Thank you so much, Norman. And thank you for everyone that's here, and thank you for everyone that's logged in online. So what I thought I'd do for this morning round of all the things, and most of the time at endoscopy, we talk about the newest tools and what's bright and what's the most exciting. But actually, I'm going to take a step back and actually taking a step back to talk about how you take innovation and actually put it into a program. Because I think often it's forgotten and we take things for granted. For example, our SCOPE program, which is standard of care zone. So I'm going to talk about how we're taking something such as endoscopic innovations for treatment of gastrointestinal cancers, how we can actually take that and implement that as a regional program, and then actually use that as programmatic care to enhance the quality for our patients and the population, and then overall increase the uptake of cancer screening and cancer treatment. So if we look back at stats, and this is every year I review our Canadian cancer statistics, which is a projection, but in the late 2000s, when it was really changed that we knew cancer was the #1 killer. It overtook heart disease at that time. And if you look at the prominent causes of cancer deaths, a lot of them are GI ones. So within the top 4 deaths, the 2 up there are colorectal and pancreas, but even the middle ones, esophagus, stomach, and even liver and hepatocellular carcinomas has actually been increasing in incidence. Most of the time, you think of how we deal with things as a gastroenterologist is we see luminal cancer, we're there for the biopsy and staging, then we hand it off to surgery or oncology. In fact, I think that the paradigm's changed. The paradigm has actually always been almost a circular and going on in a fashion. You have a potential cancer. You may or may not ask the GI to get the biopsy at that time because it depends on the MDT, which is the multidisciplinary team. Even from that, once you find a cancer, where's the programmatic care? And again, where's the GI involved in that? And then lastly, if you don't have treatments in time, you have the palliative and the comfort care team. And again, that may go back to the multidisciplinary team and the gastroenterologist. So all this may sound quite complex, but when you actually have things in programs and things are set, it's actually much easier for the patient to move seamlessly back and forth. And at the end of the day, it's GI cancer care. It's not just doing a biopsy and moving the patient along. So in terms of taking an innovation and change, this is the way that I really think about taking new things moving along. You have to think about what's currently your current care. Do you need a disruptor and does it change? So look at what's the evidence coming forward. What are the innovations that are always coming forward and which ones are going to capture next? You want to implement that and then you turn that into programmatic care That's going to turn the care and cure, and then you can go back and forth again. So I'm going to use a couple of examples to show how this has actually happened over time. You're taking something, looking at what's working and what's currently there, and actually applying and moving on from that. All right, so again, two examples. Esophageal cancer, talking about adenocarcinoma, the precursor, which is Barrett's, and then colon cancer. So this is a fairly typical case we see in our program, just subtle changes on the endoscopic view. And they're really using the optics that we have in the near view. This is a early esophageal cancer. So really stepping back over time, if you think back what Norman Barrett did for over 50 years of surgery, he actually was right. Columnar epithelium, reflux, and esophagitis. And really the biopsies, these beautiful slides are goblet cells from columnar mucosa, and we stain them, it shows Barrett's. So the reason that Barrett's is such a great example of what to study is that overall, if you look at the causes of cancer, the big ones, which are breast cancer, colorectal cancer, and even prostate, have been stable over time, if not decreasing in terms of incidence. And what's been rising, and interesting over the last 4 decades, even since Norman Barrett found this, is actually esophageal adenocarcinoma. It's by far the quickest rising of all the cancers if you look at the relative ratio. Luckily, the absolute numbers are still small, but at the same time, it's a very interesting type of cancer to actually study and to treat. So the other reason that's very interesting is that it's got a really clear cycle. So when you have repeated damage, which is reflux damage, acute and chronic esophagitis, it leads to the development of Barrett's, which is an interesting talk to itself. How does that actually happen? But where it gets really important is we're actually looking at low-grade, high-grade adenocarcinoma. And where do you intervene in that cycle? You have these plates of squamous cells. Do you interact and actually treat it when it's actually the cancer, or hopefully even before? And it wasn't actually that long ago that, again, stepping back, thinking about where we started back in 2006, that really the standard of care for almost all dysplastic Barrett's was surgery. And even the concept of even doing something endoscopically was completely foreign. So one of the big things moving forward was that you need an endoscopic change or something to innovate. And back then it was something called PDT, or photodynamic therapy. And this was actually a company, that's a Canadian company, that actually developed this photosensitizing agent. And the interesting thing is that when you gave it, it did uptake in actually dysplastic or cancer cells. Then you apply a non-thermal laser light to actually get the therapy. And so early in the 2000s, you actually had some papers. This is Overholt from Tennessee, who actually started to show that, again, using just endoscopic therapy, this was effective. So early stage cancer, high grade dysplasia, and actually showed excellent curves. So even back early on, and at the time when surgery was thought to be the standard of care, we actually now have an agent where these patients are getting treated non-surgically with actually excellent rates of response. And not only in terms of the Kaplan-Meier survival curves, but also looking at treatments. And actually at that time, they're comparing versus OM, which is omeprazole. We would never consider that now as a potential trial, but that's actually the level we were at. So this is probably one of the key slides that I have in the talk, which is how do you take that initial tool, which is PDT, and then move it on to, at the end, to have a program. And so the levels that you go through are extensive. You still have to start with everything before you just jump into the endoscopy unit or start to use it. What's your systematic review? And so back then we did a number of studies, and we're very lucky to partner with Dave Menden from Public Health and his team, systematic reviews, HTAs working with Alberta Health. Then it was dissemination. Even if you build it, people don't always come. And I remember the early discussions where, Clarence, we don't actually think there's enough people that you'll need to treat with Barrett's. This program's not going to go anywhere. So lots of ideas, rounds, journal clubs, and then meeting with the stakeholders. So again, something like this, if thoracic surgery is going to not be your partner, you're going to have a very difficult time to pass this. So partnerships with thoracic surgery, oncology, and then even with your own division. You know, without my division director back then being a steady guide and actually pulling back to make sure the program was going the right way, this never would have worked. Industry partners and foundations, because these things don't happen on their own. You actually have to partner with them. And then again, before you get those steps, then you basically need to talk to operations, because if you actually can't get this into the clinical realm and actually have your partners have the business plan, think about capital, how much it's going to cost you, think about the cost benefits, whether it's going to impact your inpatients or outpatients, what's the safety, what's the sustainability, and then you actually get to the end.
So all these factors as you move through before you get to a program are important. And then afterwards, again, how are you training yourself? How are you training your team and your nurses? And then you move to the program, and how do you actually track metrics to actually show that you actually did what you proved? So again, a complex set of slides, but essentially these are the steps of getting things through. And if you get stuck in any of those boxes, your program really is not going to move forward from just maybe a one shot. So in fact, in 2007, that's what we did. So here's rounds I gave in 2007 showing that we actually had talked to the cross and thoracics. We actually had our nurse, our dietitian, our social worker in our program. We actually had an infusion plan move through, and then we were starting to treat patients. And so, in fact, this is one of our key nurses starting to give this lovely agent in the brown bag because it was lice sensitive. Our patients had to be taught because they could actually get third-degree burns. So again, you can't, as a physician, do this. Your team was critical at this type of care. And then we actually went to endoscopy. And I would say this is the only time probably in my career I'd be wheeling something that looked like a lightsaber. And this is fiber optic cable, but that's the steps to get to that point. And really, this is what happened at the end. We were treating dysplastic Barrett's and actually some cancers. The end result, you see some Friday looks horrible. We were burning and scalding the esophagus. And actually, when you actually did the therapy, I told most of my therapeutic fellows back then, it's actually one of the easiest things to do. It's actually stay really still, shine this non-burning laser light and turn it on and let the drug work. And the dosimetry was actually the time that we spent there. And sometimes it was 7 minutes trying to stay still as possible. But the results were actually quite astounding. And this is what really started me thinking that this is really the way to go. So this is a patient that we initially had to begin with, almost 20 centimeters of Barrett's as we're moving. This is all Barrett's, almost the entire esophagus. And there was actually low-grade and high-grade dysplasia throughout. So this is the differential camera view. And then this is actually post-treatment. So same patient, this is moving past the upper airway. And now actually you start to see a little line of where it was, but this is now all neosquamous mucosa. So in some ways, even doing this endoscopically, it's almost magical. You're taking a tissue type, which is dysplastic and abnormal. You're applying this treatment and you're completely resetting this tissue to normal. So back then when we started to do this, and our little laser was also astounding. It used to be in the rooms. It's a little desktop laser that we used. We're actually very successful in actually converting a lot of patients. So obviously the next steps, how are you actually tracking what you're doing? Are you actually doing the right thing? In our database back then, the first 5 years, how many PDD patients did we have? We're going to talk about mucosal resections in a second. And when you start using something like a database, you can start asking questions. So here's an example. I had an excellent PGY2 internal medicine resident that worked with me to look at quality of cases. So very simple questions. We looked at, when referral cases were coming to the program, how many actually had the full mucosal appearance? How many actually even documented the length of the Barrett's? How many actually documented the landmarks you looked at? And those may sound like easy questions, but if you look at reported versus non-reported, it's about 50-50. So the quality of the reports coming in were actually not set. And you say, oh, well, that's just, it's numbers reporting, but it actually impacted the patients. Because when we actually remapped and looked at them, when we actually looked at and did all those numbers and the metrics, 24% of those patients got upgraded. They were actually referred for normal Barrett's, and they were found to have high grade or actually adenocarcinoma in a couple of cases. And then 15% they were downgraded. So actually we thought there was something dangerous. We treated them effectively with PPIs. And at that end, the review actually showed that they did not actually have dysplastic Barrett's. So again, if you didn't have this in place and looked at it and just jumped into treatment, you're either under or over treating patients in the program. And this is the reassurance that you need as you're going through that you're seeing the right people. So going back to the circle again. So now our new paradigm and standards, we're moving to current care, which is instead of surgery, is now PDT. And the next steps with EMR, which is endoscopic mucosal resection. And this is basically, we're one of the first in the province to do this, but simple concept, you're injecting a fluid under a lesion, you're separating a plane, you're actually cutting it off with that endoscope, you're leaving an ulcer that's going to heal, but in some ways you've got that tissue that being sent off for analysis. So again, here's another referral from one of our colleagues in the city, very, very, looks like short segment Barrett's, but very subtly, and they saw it out there when you turned on the high optics, there were cell changes, and there actually was early cancer there. This was the resection, so I'm showing the post bit, but this is actually looking at the submucosa in the esophagus, so thin lining, but the cut. And the best place to look at this tissue is actually pinned and looked at. And we actually had our team of pathologists actually go through and actually do the depth staging. So again, all these steps suddenly set where we actually have to have our nursing team move in, our pathologists move in, our surgeons who are actually involved in the decision making for this patient. And actually moving now to even this year, a couple of years ago, we had one of our students look at our entire database and looking at patients that actually went for endoscopic therapy. And they compared them to patients that actually had esophagectomy for either high-grade dysplasia or cancer. And actually, when you have the database again, you can show that you actually had benefit. So luckily, no patients died in either arm, the mucosal resection or the esophagectomy arm. But if you look at the procedural complications, it's significantly less with endoscopic therapy. And then the lengths of stay, this is an outpatient therapy. So the astounding thing for most patients coming in is that you say, well, you have an early esophageal cancer, but I'm going to treat you as an outpatient. And they go home and do extremely well. Versus the other side, esophagectomy, absolute a minimum of 10 to 12 days, and the average is 16 days. And obviously that translates into ICU admission. So this goes back to the original business plan. This is exactly what we've written down. We're saving costs from inpatients. That saved cost is what pays for the program. And again, kudos for my operational partners because they weren't looking at silos. They understood that this helped the system, and actually at the end of the line, it actually helped patients. And now the program is like this, against resetting what's back. The standard of care back then was PDT and EMR, and now the next steps are the other therapies. So now we're doing thermal therapies, which is RFA, I'll show you in a second. PDT is actually phased out, unfortunately. It got bought by an American company, but the legacies of starting that are actually what's embedded into the program. So for example, PDT, just to show you, very similar, but instead of burning the whole esophagus, it actually allows for actually focal treatments, much less pain for PDT, no worries about burns. And this, again, this is a pre-post. This is actually very subtle low-grade dysplasia. And now basically after treatment, again, normal squamous mucosa. So quite astounding. And then just to show you, this cycle never ends because this is a study on cryotherapy in Barrett's. This is Mimi Canto from Johns Hopkins. Actually, I just visited her and actually was learning her technology. But she's using cold. So in some ways, instead of burning warts, we're actually burning mucosa. And this is an example of what it would look like. But the advantage is, again, it's even safer than even RFA, even less painful. And I'm actually happy to announce that in 2 weeks, we're going to be doing one of the first cases in Alberta and Canada. We'll probably be the second site in Canada to actually introduce cryotherapy for Barrett's. And so how does this happen? This is just, again, not just one person. This is now really a team. So now we have 3 therapeutic GIs that actually established all these techniques to do this. Continue to work with operations, so a patient care manager, unit manager, CNE. If none of those are supportive, these programs do not exist. And now instead of having one super nurse that runs through, does everything, we have 4 arms that actually can rotate in and out to actually help. So that way, if people are sick, have need for the training, and again, the dietitians, the pathologists, having thoracic surgery always on board, the foregut surgeons now helping to fix hernias. And really, we've turned into an expert training center for this. And last but not least, in terms of the guidelines, is to influence further on who actually has Barrett's and may come into the program. That's important. And then again, this is our 3rd edition now working with Cancer Care Alberta, is that we're establishing guidelines so that people know exactly where to send these patients and who to send and how to get treated. So that's example 1. That's taking an innovation we think is one tool for an endoscope and actually building to program who actually can affect a population and treat that. And that, I think, luckily, is that the program has excellent legacy. And someday when I retire, I'm very happy I'm going to hand it off and have excellent people looking after it. So the other side is an example I'm going to show you is colon cancer. So again, this is actually a case from even last week. It's a surveillance case. Unfortunately, this case was delayed due to the pandemic, and totally asymptomatic patient, transverse colon, there's a lesion. And it's pretty obvious when you look at that, unfortunately, with actually our high definition optics, that this is a cancer. So again, using that paradigm again, what was our current care back then when we looked at this? What's the evidence and what do we implement to? So from this case from colon cancer, we're going to like to look at much more of a population perspective. So it's not a single tool, but how do we as a group, as a unit, as a health authority, actually look at this and actually solve this question? So again, when we started looking at this back in 2006, we knew already that colon cancer was, again, one of the most diagnosed cancers. It was actually one of the highest causes of death. And then when I actually looked at how patients were getting screened, Alberta was getting the failing grade. Most Canadian provinces were not doing well, but we were only screening 10 to 15% of the population. So this is from my original slides that I gave back, trying to convince people that we actually need something a little bit more programmatic. And back then, they were just starting to have evidence. We had evidence that fecal occult blood testing was actually effective for the population. I'm going to show you what's happening with something called FIT. And then really the important point was actually to turn these one-offs into a programmatic or population-based program. The other thing we did back then was actually we mapped the patient's path, and then you realize why patients were getting screened. So in that one-to-one model, someone gets referred and they get seen. So in this case, the green box is the patient that wants to get screened. They may not have the primary care doctor. And even if they have the primary care doctor, that primary care doctor doesn't think to send them for general screening. When they actually get the screening, they may actually interpret the test wrong. So in this case, I said FOB was positive. Instead of referring, they asked them to redo it at that time. And they even referred them because it depends on which lucky endoscopies you send through. The wait time could be months, it could be years going forward. And so this was to show, this is almost like a time study, that every step you go on, there could be potential error because everybody's interpreting the rules in a different way. So that's why this is colored boxes and where we're going in different directions. So again, what's going to shake up the system? So again, always need an innovation to change the rule. In this case, it was not just FOBT, which was good in a clinical bedside, but for a population study, no one really bought on yet. But there's new innovative things, which is immunochemical fecal occult blood testing. So back then it was called IFOBT. Now we call it FIT. But back then, this is 2007 paper looking at a short cutoff of 50 nanograms, incredibly sensitive for cancer. The specificity, as you know, we can actually make it a little bit less sensitive. You can increase the specificity. But even back then, the initial studies showed that it actually picked up advanced polyps. So all of a sudden, you have a tool that before you do colonoscopy or move in, that you might actually have a chance of actually doing this systemically. So we have Rick Saltini in the audience, so I'm going to show him a slide that he's never seen before. So when I first pitched this and Richard Fedoruk was in the room, I said, Richard, I've got this idea for a program, and it's going to be called the Digestive Health Program for Colon Cancer Prevention. And I'm actually joking right down. It was called the DHPCCP, which no one would actually have a misnomer, but this is what actually became the SCOPE program. So this is actually the seeds of actually, having support, mentorship, and looking at evidence and building it. And again, these are the early slides I show, was that the concept for this colon cancer screening program was that you'd have to have an education tool up front based on the program. You'd actually have the core program where patients were coming and getting screened. Everything would have to be logged in the database and using this for a tool for research. So even back then, 2006, that was the concept and the early design for the SCOPE program. And in fact, I think that's when Richard Fedoruk actually helped to really spearhead and really show how to spearhead and actually launch a program. I think I do give him the credit for naming it SCOPE, and that's what it actually stands for, which is Stop Colorectal Cancer Through Prevention Education. And I said, thank you very much, Richard. That rolls tongue up much easier. But in terms of looking at design, it's much similar. So we looked at the circles, when you map things out, when you actually looked at how to implement it, it was the same thing. And again, the joke here was that this is access via HealthLink. That was the tool back then. Same as Connect Care now, same as the tools before. Patients need education. They actually fall into the program for care. They need find up, they need follow up, it needs tracking in a database. So very similar to what we talked about before, but this again is the starts of actually how you get a program going. And back then we were very lucky because we knew we were moving from opportunistic care, which is that dotted, boxes that I showed you, to much more programmatic care. So patients could be dealt with fairly. Primary care doctors would know how to send. And we start to look at things for evidence. So Dan Sadowski and I looked at the first uses of FIT in the program, and this is 1,000 patients, showing very similar results to what the international studies were showing, was that this new FIT test could actually pick up polyps. And it was very good just in our limited study. SRNs is screening related neoplasms, as it's cancers or polyps that are advanced. And again, the FIT, just the first iteration, was picking up about 50% of these. So we knew we had a good base for the program. The next step again is that it's not just as simple as giving people FIT and then just doing the scope and bringing back. This is where operations and team development came in. Each of the scenarios that came in actually had to have a pathway. So what if the patient was average risk? What if they were high risk? What if they actually had an FIT that was positive enough? Which way would they go? And then when you had a finding, which way they had to go. So this is, I think, algorithm H of K that we initially did. And this was just many months of planning and meetings of every scenario to develop the pathways. And then as you see from the team development, all the people that need to be touched, we actually had to get a KT analysis, talk to primary care, operational managers, because different endoscopy units were involved, looking at the quality of the sites. How would you teach the nurses to actually look at pathology and give recommendations? How do we actually give further surveillance communication to the primary care doc and the patients? And then obviously the waitlist management. So again, all of these happens with planning and for forethought, but from a very simple concept, which is FIT screening for colon cancer screening, which seems very linear. There's a lot of steps again through the business to actually get this into a program. And so again, this is one of our early slides that I remember helping Richard give, and as we're pitching this concept for more regional model, it was a scope plan. It was the first time I'd heard of a POC back then. This is the proof of concept, Clarence. This is what we have to do it, and then moving to full program. So it shows you, and again, and I'm very thankful that I have excellent medical leaders now in Rick's in the room, but it took a long time to get this going and to get this right. And now it is considered the standard of care. People know that the scope program is standard, high quality, and it took this in terms of a beginning to actually get it to the stage. And again, we finally defined who it was. Rick, you probably laugh at me again. This is our early intake form and how ugly and crowded it was. But again, everything starts somewhere in terms of where you have to go and allows for modification. And again, luckily, I have two excellent co-leads that actually took this, and now it's region-wide. It's a single point of access for this. It's coordinated endoscopy. We do screening at 8 sites across the zone. We collect the data for this, and actually it's an ongoing checkup quality. So almost everyone knows that if you get a patient in the scope program, the endoscopists are vetted. Report cards were a little bit late because of the pandemic, but regularly watched, so everyone knows that there's metrics on the endoscopists that are in there. Then the next step that we took was that in the scope program, the learnings, we actually took this now provincial and asked the same questions. How was screening done? Where was it being performed in Alberta? And it translated into this. So in 2013, when I took over the provincial screening program, we actually officially launched FIT throughout the province. And you can see in terms of the pitches of the graph that in 2013, that was the number of FOB kits, about 170,000. And now every year since then, it instantly jumped to 260,000 tests a year. And we're getting close to the high 200,000, 300,000 FIT tests a year. So again, with that same model of implementation, near instant impact. The other things about the program is that we're able to actually start to look in the data. And that's the other things that we have is that data drives everything as we move on. So this is a heat map. This is LGA, which is a local geographic area. But we're actually able to look at who was doing FIT tests and where things were hot and cold. No, this is not a political map. It may look at it, but it isn't. But this is actually a screening map, so I could hone in at every single point and see where FIT test was being done. So this is Westlock region that I highlighted on the screen. And actually, then we could actually think about targeted programmatic change. The other part was actually, we were one of the first ones in the program to say, where is endoscopy happening in the province? And believe it or not, in 2013, no one had actually done this map before in this grid. So back then we knew there's approximately 54 sites, there's 50 now. But again, doing this as a program and wondering where screening was going and then applying these changes, I think that's how actually you could actually move things forward. The other things that we did in the program, which again are almost side notes, but are standards now, is that there wasn't a unique bowel prep. I think some of the studies even done out of Edmonton of our U of A group showed that bowel preps were over, the quality was all over. So I think one of the least flashy things, but probably one of the most important things we did in the program was we did actually the standardized colon cancer bowel prep form, which is actually free for download, and actually endoscopists from across the province can actually order this and actually have this sent to their offices. And then Dan Sadowski again looked at other quality markers. We looked at PCCRCs, which is post-colonoscopy colon cancers. So again, quality check, were we missing things, were we checking things? This was done through the PLP program when I actually sent report cards. And one of the things that I have to get back to is that we expect to do ongoing iterations of this. And then we were trying to figure out why. It's not just bad endoscopists, but there are other factors that were involved. So last of all, I'll just end off in terms of program quality. We knew that of the 50 sites that there's different ways that there's being done. And so programmatic quality for endoscopy, it doesn't matter how good your program is, it doesn't matter what the FIT test is, but if your programs have different links in terms of quality, it's going to change. So working with the Digestive Health SCM, we're very proud to say that we actually looked at our sites and actually implemented as policy that all endoscopy units in Alberta have to follow the global rating scale, which is a quality scale. And that's not a small undertaking, getting all the units to actually submit, to actually have it embedded in policy, because I think from that, again, you can start talking about, you know, are units doing the right things? Is it sustainable? can you actually get this and move this to all the different units? Should they be doing screening? And so you can start to ask all these important questions. So moving back again, what's current care and what were we at? So 2005, Alberta was 10 to 15% for screening. Jumping ahead now in terms of, this is 2020, this is CPAC data. Again, I'm very happy to show that Alberta was actually, of all the percentage of fit screening, we were actually the number one in terms of the provinces. So from a very short period of time, we went from almost no baseline screening, almost up to the projected standard, which is 60% should get fit screening first. Now, the reason that it's not quite there is that we know there's a mix of patients that have had colonoscopy before. So UTD means up-to-date screening. That's any method, FIT, colonoscopy, sigmoidoscopy. And again, just to show you that Alberta in the first box is very competitive across. We're one of, again, the top screening provinces in the country. So again, not a small amount to move from 10 to 15% screening to now we have nearly 70% of the population up to date for screening colon cancer. So I think it's quite an amazing amount of change, but I think it's, again, not just an idea, it's getting the program to get people involved, to get really smart people involved from an NHS perspective to help with this. And it truly is a team concept and a teamwork to actually get us to this point. So hopefully, and thanks for bearing with me, we've had our tech challenges we've gone through that I've shown that, you know, that as much as an endoscopist like myself, we think about the patient in front and the scope one at a time. If you take that next level and you look at endoscopic ablation, you apply the tools on it again, you can actually use it as a template to actually innovate. And then with colon cancer, I think it's really the power of looking at it programmatically, not only at a local level, but a provincial screening level and the amount of people that you can impact. And then throughout the way, I just have to give thanks because of my talk is, again, when you have a division director back then, that's actually not only encouraging, but pushes you in the right way to actually develop a program. None of these programs would have actually happened without Richard, because it was his guidance and his forethought that actually got these programs going. And I would say mentorship, because a lot of this was teaching one generation to the next how to get this done. This vision as well, because they're the ones that actually had to back this. And I did have to convince a number of people these were the right ways to go. But at the end, they're the main partners. They're the ones sending in all these patients. Without the stakeholders and partners, which I've been very lucky with, and actually people across the world, around the world, have said, Clarence, why do you have such a good collaborative group? And I said, it's actually quite amazing. It's iterative. It's been very open dialogue, but I have a very supportive group of thoracic surgeons over time in oncology. And then lastly, and last but not least, is again, operational partners. I think we discount this at times, but if you don't have operations back you from a capital health and the NHS perspective, none of these will happen. There's extremely hardworking, smart people. I'm always, I shouldn't say always, but astounded by the number of skilled people that I have to actually lead this. You have a concept and you know it's effective, but really it's all the people that are around you that actually make this effective and work. So with that, thank you for your attention. Thank you for bearing through the technical issues.
Actually, I need to thank Clarence for bearing through our technical issues. So thank you, Clarence. First of all, what an amazing masterclass on implementation science. And I love this talk, because I think for a lot of people out there that, wonder about these other areas of scholarship, like you just gave a perfect multiple examples of how clinical innovation can happen in a scholarly way. So thank you so much for that. So my question is a little bit around, again, related to implementation science. The one thing that people struggle with the most, and I loved your diagram in terms of the how-to, but the reality is, I think you really undersell yourself in terms of how much of an influencer you are. And so, can you, particularly for some of our early and mid-career people, can you just talk a little bit about how your ability to influence, what are some of the tips and tricks that you've learned through the years in terms of how to bring people along?
Thanks, Norman. It is a good point. And sometimes it feels like it's a lot of,
Sorry.
Yeah, so it's a lot of discussions, but that's really what it is. There's a lot of things that I can remember, meeting rooms, coffee, sometimes over a beer. There's some people that don't agree with you that you have to go through. And then on the other side, I think in terms of even operations in NHS, it's really your job to really explain through the science of why and to convince them that this is it. And some of them take it up, some of them are still are hesitant. But I think at every step, you have to understand the other person's perspective. And all your stakeholders will have different things. The surgeons are thinking, am I going to actually lose business? And actually, again, we had incredible partners that actually knew that if we save this part of surgery, they would actually be the other things. So one of my things that I do take credit for is I think I increased lung cancer surgery because I freed up all those thoracic surgeons from doing esophagectomies at the end. But I think at every part, you have to realize that you're a partner. And then it's true that over time, I've learned more and more that you actually have to understand the other side and the stakeholders and every step that you have to do to understand where the perspective is, because otherwise you can't move your agenda forward. And if you're fighting with them, everything stops. And you can't fight, you have to actually do this together.
Figure out a win-win.
Yes.
And there's always business is the other
It's
thing.
always business, yes.
Okay, there's a question here from Quentin asking, are data on occupational exposures collected and addressed, either through WCB reporting or something? He asks, there are a number of workplace exposures associated with different GI cancers, and I wonder if you can comment on that.
That's actually a really good point. We're not quite there yet, but for example, even our program, we actually have a little special box for firefighters. And so we actually let those in programs in earlier. I actually don't think that we actually do enough in terms of tracking. And I remember some of our initial planning, we did talk to some in WCB about that, but I think this is again, an opportunity for more partnership. Who are the ones actually in WC that may be at an increased risk of esophageal, gastric, pancreatic cancer? That's a whole nother talk, but why is there a rise in pancreatic? Is there something systemically out there that we're missing? So I think that's an excellent question, and we have to do more. No, and I don't think we have enough of those connections.
It sounds like a great collaboration.
Yes,
for
yes,
junior
yeah,
faculty members.
yes.
Clarence, I wonder, as a non-endoscopist looking at a lot of these procedures that you undertake, and even, a few weeks ago, we had that double balloon endoscopy presentation. And it seems that there are a lot of potential issues around, complications and things like that. And, you talked about a lot of these procedures happening in various places. And I wonder if you can just talk a little bit about the level of support you need, because, in a place like the Edmonton zone, where we're very regionalized, the thoracics is only available in the Royal Alec, and what is the risk with regards to doing these types of procedures at sites where there isn't that backup and things? I've just always wondered about that.
Right, so good question, and I'll say very cautiously that we're very quiet in GI, because as a lot of things moved and we had an innovation moving along, it was a lot of one-offs, and people are doing that. And I think as we're moving forward, and we are one big region or zone, that's one thing we're asking, that again, you take the innovation, you think what you can do, but you actually have to pass through. Is the person doing it safe to do it, and they've been trained adequately? And I hate to say it, but in the past, some of them were weekend courses, and they would come back and try the implementation. And I think this is 2022, none of that can happen anymore. So again, that's working with operations and then starting to work with your partners and track it, because with all of the things that we did, working with operations, one of the contracts that we actually had was, we're going to track patients, we're going to show you that's safe. So I know over time that I've had no patients go to the ICU, the entire implementation of my program. I know with one hand how many patients I've admitted over the years and what's happened to them. And actually, even now that we're 3 gastroenterologists, every single cases that have that, we actually almost do a mini QI with something goes on. And I think that's the level of really forward-thinking intent that you have, instead of being reactive to those, being a proactive. So again, most of my division knows, as I've talked to them from a section chief point of view, I love that everyone's doing innovation, but we actually have to do this the right way. We have to track this, and it may seem like a lot of dotting I's and dashing T's, but it has to be done correctly. And the right people have to do the right things. I'm not going to go in there and treat complicated decompensated cirrhosis. Same thing. I don't expect every endoscopist to do therapeutic things. The right people have to do this. So again, I think this is an organizational map to go forward. But again, my pledge back to people that are above me, report to, is that they need to trust that we're doing the right thing, that we're actually looking after patient safety. And again, I think even with HS, they're asking us all at the same time, and our operational leaders, that they're trusting that we're doing the right thing and we're doing this for patients. And I think they see it. And when they see it, there's that whole snowball effect. They know that you're doing it right. They support you, you support them. And again, I didn't mention, our executive director for the zones, Kim Kostiak, we have total trust working together. And that comes with time and actually being transparent about this. And I think if it wasn't, you don't work as well. So.
Yeah, you and Kim work very well together. Okay, there's a question here from Claire Lee. An issue I've heard about is the wait times in the Edmonton Scope program for colonoscopy. Apparently, our wait times are significantly longer than Calgary's. Always those urban myths that go around, but you can confirm that. Even when corrected for volumes. Can you comment on what the data may be showing on this and possible reasons as well as opportunities for improvement?
Great question, Karen. So there's no doubt that during the pandemic we go through, just pre-pandemic, the wait times for FIT screening were pretty much close to the 8-week mark, which is the benchmark across the world, which is 60 days. During the pandemic, we saw a massive rise in that, very understandably going forward. The one thing that I can compare to Calgary and with CCSC in Calgary going forward is that they're a few years ahead of us. And so one of the things that they have is actually much more funded programmatic spots. So they're almost doing double of what the Edmonton zone is. And part of this is, again, for many factors, but in terms of the planning, we actually haven't increased our funded spots over many years. So again, that's one of on my agenda, one of the main things that we have to do. So what's happened in Edmonton? So this is what we're tracking, but we know that outside there was actually a lot of screening going outside in individual endoscopists. But what we really have to do, and we have to move that, is that all screening has to move in the program, which is what they do in Calgary. So Calgary has much more a sense because they're tracking it central and there's much less scoping outside the program. In Edmonton, we're about half and half. So it's taken time to get there. So I think once we actually do that, I'm actually, and again, our scope programs worked really hard. We're actually now moving closer and closer down to the metrics of normal. But we're also prioritizing. So for example, a patient with a first-time FIT is being prioritized over someone that's had repeat endoscopy multiple times. And so we're able to make these decisions, and some of them are difficult, but we're actually doing is to try to actually treat the patients and the groups of patients that are most needed for the forefront. And again, that's something that these are ongoing regular meetings trying to plan to do that. But at least we have a chance to actually make the improvements, because in the past, it was literally every single practice that you're trying to convince and you have no ability to change. So excellent question.
Thank you. Thank you. Meaningful answer. Somebody's asking if the age cutoff for FIT testing that has now changed based on recent data.
Great question. So controversial. So right now, average for screening is still starting at age 50, moving forward. But there's actually many groups, even in the US, that are actually recommending we start to move down to 45. So I think in Canada, we are not there yet. So officially, the answer is no, but it will be happening. Now, the one thing in Alberta that is a little bit different is that we do allow FIT testing at age 40. But what we actually were doing is allowing those people with family members that were a little more elderly with cancer to actually screen. In the old days, it was, oh, your dad was 92 with cancer. Okay, everyone needs to be screened. And obviously, we know that's not right. It's the younger ages, which were high risk. So what we did was, instead of just telling patient, no, we don't think you're at risk, we actually let them start FIT screening earlier. So that was, again, an innovative program change that we designed. But I think systemically and for the province, we're probably eventually going to move to start the age 45, but we're not quite there yet. In fact, no provincial program is there yet, but I suspect we're moving that way. And my operational parts, if they're listening here, everyone's a little bit worried because that's a whole big part of the population that's going to move in. Even from 50 to 45 is a lot of people to add to the program.
Questions keep coming. Dr. Armstrong's asking, well, first he says, excellent model and great to see Richard Fedorik's roach still burning. My question relates to aligning the economic incentives to the mission when physician funding from different groups is fee for service and some in salary for others.
That's a great question. We absolutely hit that right on in terms, because again, this is why I even listed it. It seems obvious, but you have to have your GI partners involved. There were many meetings, and I think maybe Norman, you intimate this. There were many 5 p.m., 6 p.m. meetings with people across the zone, very worried about this program affecting, fee-for-service models, that and how it would go. And at the end of the day, what I always promise them is that, and I think it's happened, you will be as busy as you were before. You're just going to see patients that are much more appropriate because they've been pre-screened. And so I think that was the first one to actually talk about that. The second part is that it's really easy to get siloed. You know, I'm thinking about my own practice. I'm thinking about my own hospital and a unit. And again, to try to get people to think much more about conceptual team view and a region view. And that was a major shift because we were not, you know, every hospital different, even people within hospitals were running their practices differently. So that's why I showed that grid. People were going through in so many different steps and ways to get care. But I think that was, again, maybe you said that, Norman, is that those were all those talks beginning to show people at how, you know, they're going to be fine through the program. They're going to be as busy. And in fact, we now have, through the pandemic, we actually have regional zone spots that have opened up. We have great partners. We'll open up spaces at different hospitals. We'll use any spots available so that, you know, Dr. Saltani can go to Fort Saskatchewan or Westview. And so we're thinking outside that box, which means that the asset that's available is being used appropriately. And I think, again, it's changed over time to convince people, yes, you will be busy and you'll do that. I just want you to be busy seeing the right patients.
Yeah, again, reiterating, there is not a shortage of business.
That's right, exactly.
So there's excellent talk. Can't help but feel like we're on the precipice of a big change in the delivery care model in Alberta. And with the growing pressure for privatization, or at least non-hospital facilities,
Yes.
your programs really mentioned the importance of oversight, quality, and measurement. We see the downfall of that in Ontario with private endoscopy suites, with a complete lack of oversight. How do you see us achieving efficiency, privatization, yet still holding people accountable with high quality?
Yeah, so that's an excellent question from Rick Saltani, and obviously we're seeing pressures of privatization moved in, and actually people across the country are shocked. They said, Clarence, are there private suites in Alberta? I say, no, Alberta has no private endoscopy suite. People are shocked to hear that. So I won't lie to say that we have not been talking about this with governments and with that throughout the pandemic and moving forward. I think the one thing, again, using Ontario as the model is that when you don't have oversight, you're going to step back from what I showed you to that little boxes of people doing little things on their own. So I'm a firm believer that we can think about a P3 model to maybe improve costs or innovation, but the oversight has to be still at an upper level. That my promise to the industry moving is I'm going to fill all your spots. However, I think that the patients coming have to follow a programmatic model. And again, I think it's all win-win. We have a lot of patients that need to be seen. If they can be seen more effectively, and again, working through with the HS or government, I think that we can do it the right way, but we can't allow that slippery slope where people are just, again, booking whatever I think it is. People are well-meaning, but when you actually have little boxes over, practice starts to really disseminate.
Just going back to your previous question about fit, Angela is just asking, what would you say would be a reasonable upper age cutoff? Speaking of useful or reasonable use of resources.
So thanks. So there's the two controversies that actually hit over time, that the younger patient and in fact, the older in terms of the older cutoff. So right now across Canada and the world, the upper cutoff is 75, and it sounds like it's an arbitrary number. But the reason why is that if you actually look at a lot of endoscopic studies, once you start doing regular colonoscopy over 75, the risk benefit ratio starts to level off. So in fact, you're right that as we test fit, we know this, that as the fits per decade move up, your positivity rate starts to increase. The issue though is what benefit are you actually having for patients? You know, how much are you increasing their quality of life, even if you diagnose them with cancer? And also the last thing that we don't want to program is that you're over-screened to the point where you're generating complications. So right now we still stick that 75. However, we say that, you know, after 75, we know there's 85-year-olds that run marathons. It is much more of an individual discussion, but really we should be very careful about thinking about screening over, because over-screening causes harm. And so those are what we call stop rules. And I would say all the provinces are behind. We're starting to have that about, you know, I'm not just stopping because you're, you know, it's very insulting. I'm 76. And what do you mean I'm not worth being screened anymore? It's a much more complex discussion. And I actually don't think that we have the right wording or the science to tell people and teach them why we're stopping. It's actually to still to improve your quality of life.
It's not about the ageism, it's about what the overall benefit.
That's exactly it.
Really interesting question. Patients with a family history of neuroendocrine cancer, is there a recommendation for colonoscopy?
Right. So certainly in my work, we deal with a lot of NETs or neuroendocrines. And we actually, the one thing about the scope program is that we've actually found a lot of carcinoids that in the rectum over time. But still, between this and the international recommendations, we don't think so. We think these are one-off still that happen. We haven't seen the family pattern. But also the thing is, I don't think I've had a good resident even track all our cases. So that might be a good potential project because we actually do have those in the program, all the nets and that we've seen. But the answer right now is we don't think so, but that could be an excellent question to ask.
Great question. Okay, well, what a fantastic presentation, so clinically relevant and such a good, opportunity to learn how to implement. And so thank you, Clarence, on behalf of the department.